physio exercises are inherently boring.
They're so boring.
So can you integrate it somewhere else so it either feels like you're getting it for free because you're boiling the kettle anyway and you're climbing the stairs anyway, or can you just put it in your gym program where you'd be doing a warm-up perhaps anyway? So I'm fully in with just adapting and playing these tricks on your brain just so it can fit into your life somehow.
Hey, I'm Hypermobile, and if you're listening to this, I'm guessing you might be too. Hi, my name is Alex, and I'm your Hypermobile host, and today we are talking all about ankle sprains. I have on the incredible physiotherapist, Charlie, and Charlie's here to go through everything from what patients really need to be aware of, people who might even be at risk for ankle sprains, and kind of all the advice he wishes that his patients had before they ended up seeing him in clinic. But first, before we get into all that, Charlie, please tell me about yourself.
Hello. Thanks for inviting me on, Alex.
Thank you for being here.
Well, I'm a physiotherapist by trade. I probably these days identify more as a physiocoach. I just prefer the mindset around coaching people towards their recovery rather than therapying people better. Not to say that we don't end up doing an element of therapy in some sessions, but I just really prefer that mindset that you're facilitating someone to fix themselves rather than we do the fixing. But that's semantics, I guess, and I still love my job. I love what I do, fixing patients, helping them get better. And but these days I run a business as well, so I run Better. So Better's a physiotherapy clinic in London. So we've got a team of physios and personal trainers that are all hopefully doing the same thing I do and helping more people all at the same time.
That's brilliant. And you also have a podcast, right?
And that's where we met.
That is.
Yeah. So you were very gracefully a guest on my podcast, telling my audience about hypermobility. And so I host a podcast called the Physiocoach podcast. And we're really trying to spread that idea about physio coaching to other physios, just to help people see things a different way and just spread more good news around the community.
No, that's incredible. And I think language is so important. I think we spoke about how my first degree was in English literature, and words matter in terms of both how we think about ourselves and how we interact with patients, people and broader aspects of life. So I'm totally here for that. Now, I did look you up online to do a little bit of background research, and I saw that you have a lot of experience in sports-specific settings. Could you tell me a bit more about that?
So my first passion was sports. So as a kid, I played sport any way I could, any time I could. And I happened to be quite good at school, but I knew that I really wanted to be involved in sports. That was the main thing. So when I was getting to the point of figuring out my career, it was always about how do I make sport a part of that. I wasn't quite good enough to play, which I realised fairly early on, but I knew I'd be involved somehow. So I did sports science as my first degree, and that took me on a really great learning journey, actually. I really enjoyed the science of sport and the body. But by the end of it, the career pathway for that just didn't quite fit me and what I wanted to do. A sports scientist was quite hard to get into. There weren't that many of those types of jobs around. You often had to do like a really cheap internship to get into it. And I just felt it wasn't quite me as well. I'd wanted to be a physio as a teenager. I liked when I was watching sports, seeing the physio go on the pitch, help people with injuries. That always looked quite a cool thing to do. I was put off it a little bit, actually, which is why I didn't go for it to begin with. But once I'd done my sports science degree, it just kept coming back to me that it was an opportunity or an option for me. So I did physiotherapy as an MSc. It stuck from there. And because of the sports passion, my idea was always to be a sports physio.
Beautiful.
So I went into a normal physio job to begin with, but always had my eye on sports roles and was doing some work in rugby, in amateur rugby, and then managed to get a role with Saracens. So I did a season with Saracens Academy. I also worked with the Football Association in disability football and futsal as well.
So wow.
And that was great. So I've spent most of my career doing sports on the side, I suppose, as like a side career, and then musculoskeletal physio as my main job. And although I thought I'd be a full-time sports physio, I really love the complexity of treating the everyday patient, the everyday person, because they just come with so many cool things. There's so much more interesting about different people, whereas athletes are athletes.
I know.
As high performing and as fun as the good stuff in match day can be, sometimes sitting there watching training isn't so exciting, and watching a gym session isn't so exciting.
Yep.
So yeah, the everyday person is just way more interesting and complex. I love the problem solving that comes with that.
I love that. And I did notice as well in your bio, just looking around online, that you love working with complex and chronic and treatment-resistant injuries. And I found that really interesting that we have that passion in common. I have to ask you, because I had a similar thing happen with myself. I didn't want to, and I didn't mean to end up in the field I've ended up in, should I say. For the record, I'm an osteopath. So osteopaths do manual therapy and rehabilitative exercises. Physiotherapists are another type of profession. We do, as a profession, they have more in common than different, although of course there are subspecialties and there are specific types of physiotherapists, like stroke rehabilitation physiotherapists, respiratory physiotherapy, etc., which osteopaths are not trained in. But as someone who was also put off going into a kind of similar line of work, what put you off it?
At the early stage, I mean. Yeah. Well, it was just, I didn't have a huge amount of confidence. So when I was a mid-teenager, I guess, when they were saying, what do you want to do? And I said, I want to be a physio. And they said, you need really good grades for that. And because I wasn't like super academic, I would pick things up fairly easily, but my passion was always sports. So when my grades were like quite good but not amazing, I just thought, maybe it's not going to be the thing that works for me. So yeah, I think I was quite easily swayed. It was quite a flippant comment, I believe. But it was only when I then did pretty well on my degree that I thought, actually, when I put my mind to it, I can achieve just fine. So it was something that came later in life.
It's interesting how those little comments kind of such big consequences. And I do think sometimes that some of the most incredible people in this field, they often are people who come to it later. Like everyone has their origin story. And I always just find it quite interesting to get into that. I'm so happy you ended up here. And I can't believe as well that you had a little bit of challenges from an academic perspective, given how much of a wealth of knowledge you have now. And it just goes to show like how people learn and, develop these skills in different ways.
I think some of it was more apathy than lack of ability. It was just
maybe.
And what you say about coming to it late, more of it was just like wanting to learn. I didn't really want to learn until I was a bit older than maybe some others. So much more interested in just playing sports or whatever else. And when I got to university, I suddenly realised, hang on a minute, no one's going to do this unless I really knuckle down. And I got to work then.
Oh, that's so cool. And I'm so happy you ended up here. So without further delay, let's get into why we're here today. So when I was on your podcast, we talked about the phrase, it somehow came up, I can't remember, but we talked about how people say it's just an ankle sprain. And there was like this moment where I could tell like we were going to have good vibes. We connected on that. Tell me a bit about the phrase, it's just an ankle sprain, or why that was something that kind of sparked the whole discussion we're having today.
Well, it hits me deep. And the reason it hits me deep is because when I was 16, I had just an ankle sprain.
Oh, no.
And I remember, so this is before my physio journey, of course. So playing rugby, fairly new into rugby, and I was running with the ball. Someone tackled me. They landed. I was running that way. They were kind of behind me and tackled me from behind. My ankle was then stretched into an open position, and I felt an immediate pop in my ankle with the weight coming down on top of it. The worst pain I'd probably ever felt at that point. Really sore. Came off the pitch. Pain settled down relatively quick, as an ankle sprain can do. So within 10 minutes, it was like, okay, it's throbbing, but it doesn't feel that bad. Managed to hobble to the car and went to the hospital. And then that was where the phrase "just an ankle sprain" was presented, and it's like, no, it's okay, it's just an ankle sprain. And I went away with the advice of keep it moving, roll it around, stretch it, maybe take it easy for a few days. You'll be fine. You don't need crutches. Just take it easy and then get back to sport when you feel ready. It's like, okay. Nodding my head. Okay, I feel very reassured. Thank you, NHS triage nurse.
Did they give you the rice thing?
They gave me the rice thing. Yeah. So rest, ice, compression, elevate. Okay, I'll do that. So I'm nodding my head and thinking, okay, I feel confident that I know what to do here. It was really painful for a few days, maybe a week, and very swollen around the outside of my ankle. So I definitely had an ankle sprain. So categorized as, the tearing of ligaments within the ankle, and that had happened. And I remember thinking I need to keep moving on it. And I've got this vision in my head of being in college and like limping down the hallways because it was just so sore, and I'm trying to do my thing, just keep walking on it, keep moving on it. And then 3 months goes by and I'm like, just about like, I think I'm ready to maybe go back to sport again. So like 3 months, that's not an insignificant amount of time.
No.
I wouldn't say just could be attached to 3 months. You're just going to be out for 3 months. So that sounds like quite a major injury to me.
It's a lot, especially when you're young and time feels very long back then.
Yeah. And I did get back to playing sport and played sport another few months. And then I had another just an ankle sprain on the same ankle.
Wait, so how long after the first injury, that
So
second injury?
it was certainly within a year. I had it again. And it was ironically on the same pitch against the same opposition, playing the same sport in the same way. So history repeating itself. It wasn't quite as painful this time around, which I now understand is because the first one's always going to be the most painful because you've got the most fibers to snap. So the one after that, the healing wasn't as good as it should have been anyway, and we'll get to that with time. So it's still sore, and I knew what had happened this time, but the same thing had happened again. And I think this time I was at university, so I missed a really important chunk of my rugby at university because I was just getting into it, really enjoying my sport. I just got into the first team, and I was disrupted by this injury again, this just ankle sprain that had just come back. I had some physio at the university. It wasn't particularly, I mean, now I look back in hindsight, it's like it wasn't very good, but I paid £5 for it. That's pretty cheap. This heavily discounted, subsidized physio. And she gave me a bit of advice about balancing on it and doing some calf raises. And from that point, it was a bit better. So I remember having another episode relatively shortly after that. It wasn't that painful, but it kind of gave way. But I mostly got back to rugby. And for about 20 years, my ankle was mostly fine. It would always feel different. It would always feel a bit less stable and a bit less strong than the other one. But it was mostly fine until a year and a half ago. And then I went running, was running on this really uneven ground, and I felt my ankle really give way again, the same one. It wasn't that painful again, but I knew I'd done something. That feels different. From that point onwards, it was unstable just in daily life. So I would roll my ankle on the street. I'd feel nervous when I was walking. I'd be looking at the floor a lot more. When I was out for a run, I'd be looking at the floor all the time, and it would roll and give way. But because there were no ligaments left to hold it, it would be really lax, but it would also not really hurt. So I made the decision to speak to a sports medicine consultant who did some scans. And at that point, so this is now 20 years after the original injury, we realized that it wasn't just an ankle sprain. It was a full rupture of my ATFL ligament, one of the main ligaments on the outside, a full rupture of my AITFL ligament, which was the one, like they would call that a high ankle sprain, and a partial tear of the PITFL, the one on the back, which we surmised is probably the one I did recently when I rolled it when I was running in the fields. So at that point onwards, I had a decision to make around getting surgery to reconstruct the ankle, or whether I could carry on living the way I wanted to live. And with some thought and a really long hike later, where I did 3 days of hiking and probably rolled it about 30 times, fell on the floor maybe 5 or 6 times. It was that trip where I suddenly decided this isn't coping. I'm not coping with this anymore. I need to do something about it, and decided to have stabilization surgery, which was November last year.
Alrighty, so before I ask you about that, just to clarify for any listeners, so you injured the ligaments on kind of the outside of the ankle, is that correct? Yes. And you did a few different ones, essentially, which is a very classic thing to see. It's often not just one ligament, it's often a few things going on. You ended up having surgery. How did that go for you? Because I've seen a few patients who have ended up having surgery. Not everyone needs to or does, but when it's the right clinical decision, it's the right clinical decision generally. So
exactly.
Tell me about that.
Yeah, and because I'm a physio, I see these a lot too, and I know that some people don't need it and they could do really well with rehab. So I did my exercises and I was doing all of my work, and I could do a single leg pistol squat, I could do a single leg sit to stand. I could do, when I was stable and stationary, my stability was amazing. But as soon as I was moving around in the world, the structures weren't strong enough to hold it. So it would give way all the time, and it would collapse in the most ridiculous of moments, walking in the road, stepping on something in the gym, or just something really menial. So yeah, the surgery itself went very, very well. And I'm now feel really confident, and I've been on a similar hiking trip since, and I didn't roll my ankle at all, and it felt super strong. So it definitely worked for me.
That's fantastic.
It's no insignificant thing, and that's why I really gave it some thought, and it really does. I'm 6 weeks non-weight bearing with that surgery in particular, so 2 young kids and a wife who would prefer me to be weight bearing at home. There's it's a really important thing to weigh up. Can you handle the recovery that's attached to the surgery? Is it worth it? And no surgery comes without risk as well, and
Absolutely.
so it's a lot to weigh up. But luckily for me, it did go very well, and now I'm back doing everything I want to do.
Cool. In simple terms for listeners, what did the surgery involve? Like, how did they try and repair the ankle?
So it was essentially it was a double surgery because of the different injuries that I had. So the ATFL, which is the ligament lower down on the ankle on the outside, that's reconstructed. They attach the outside shin bone to the foot, and then the other one is more like a wrap. They kind of surround the two shin bones to hold them together. So you're a big shin bone, the little shin bone on the outside.
I like those names.
And they tighten it.
Yeah.
And they tighten it together. So there's like a wrap around it, and then they tie some knots to make sure that it stays there. And I was actually quite lucky that my one of the lower ligaments was actually still in there but flapping around. So he said we were quite lucky because he then attached that as well to the bone. So I've got like a double repair on the front.
Reinforced repair.
A reinforced repair. So he said not everyone has that, but because it happened when you were young, he said like you get all this big like healing response. Although it didn't heal fully, all this healing response happened, so it was still in there. So that was quite lucky for me.
Oh, that's brilliant. You'll have to tell us more a little bit later about some of the exercises you did after the surgery, because I'm guessing there was a long journey even after that 6 weeks being off weight bearing. But getting back to ankle sprains in general, let's talk about like ankle sprains and hypermobility, because we know there are certain risk factors for ankle sprains. I'm sure you'll be able to tell me about a few of them. But being hypermobile or having even just an ankle that's hypermobile, even if you're someone who doesn't have a connective tissue disorder involving hypermobility, it's going to be something that puts you at risk for ankle sprains, right?
For sure. And just starting off with my journey, I'm on the bendy end of normal. So I'm not hypermobile, but I am quite a flexible person naturally. So I'm at more risk as a result. And then you go further down that continuum. And for sure, like if you're hypermobile, you have much more movement that happens through your ankle joint. As a result, just the tiniest little kick off a stone is more likely for the muscles to not be able to handle that force. So then the ligaments are exposed, and those ligaments are strong, but sometimes they're not strong enough, and they might fail, and that's when you get the tearing of the ligament and therefore the pain that comes with an ankle sprain.
So in terms of risk factors, are there any other things you look for in people? I've read that like asymmetry. So if you have like some people see me, they're like, Alex, I have a great right leg, but my left leg is horrible and stuff. Are there any other risk factors you kind of screen for when you're looking at patients?
I always look at calf strength. So that for me, the best way to do that is to compare the height of a two-leg calf raise, so how high their heels are off the ground versus their one-leg calf raise height.
Ooh.
So I'm measuring that with just a ruler, actually, straight out the pencil case. And the two-leg is their range of movement, and then the one leg is their strength. And if they're weak, their single leg is quite a lot lower than their double leg. If they're strong, then their single leg stays at pretty much the height. Maybe it drops by half or 1 centimeter. But with a weak calf, you could get as much as some people can't even do it if they're really weak, but anywhere in between, really. So I prefer that test to just measuring how many calf raises they can do, because they might be able to do the same amount of reps on each side, but how high are they going matters more to me. So I first check how high they go, then I'll count how many reps they can do on a capacity test like a calf raise.
I love that and how sensible it is. And I'm definitely going to be stealing that for use with my patients. When it comes to ankle sprains, another thing which has come up in your story in particular is how a previous ankle sprain can potentially increase your future risk of ankle sprains. How important do you think like medical history is in terms of previous injuries? If someone's listening to this and they're like, I've had 2 ankle sprains or I've had 10, like there's someone who should kind of be starting to prioritize maybe dealing with this, right?
Yeah, it's the biggest predictor of future ankle sprain is to having had a previous ankle sprain.
Yeah.
And what you actually tend to find is not just that the ankle sprain increases the risk of ankle sprains, it increases the risk of lower limb problems, full stop. So it's much harder for the evidence to track the relevance of that because there's so many different presentations. But I see it in clinics so often that they've got a knee or a hip or maybe even a back problem, and you ask them and they say, oh yeah, I had this ankle sprain when I was younger, and you watch them move and you can see it. You can see the lack of stability on one leg. You can see the calf raise isn't quite so high. You can see that they just don't move quite so confidently on that side. So yeah, the history is super important. And the other thing that I would screen for is how stable are they on one leg. So just get them balancing on one leg, and how able are they to single leg sit to stand. I think I mentioned that earlier. So just getting them to sit down on a chair, stand back up again. If they can't do it, then raise the chair up, because it just gives you so much information. What does their foot do? What does the ankle do? What's the knee and the hip doing? Does the knee drop inwards? Does the arch then collapse? So I'm using a lot of these terms here, but essentially, does it look strong and stable?
Yeah.
And you can do this yourself. Just get in front of a mirror and observe it, and you'll see yourself that one might look different to the other. And if it does look different, can you just try and match the other side? Can you change it yourself? This is the physio coach for me. I like people to be able to figure out the problems themselves. I can see that now. Yeah, when I was just feeling it, I couldn't tell, but now I'm looking at it and observing it in the mirror. I can see that. Yeah. So if you try and just mirror the other side, then you can often just do a lot of the work yourself without necessarily needing to see a physio.
I think looking for those little vulnerabilities in terms of movement, why does my left leg move this way, but my right leg moves this way? I think that's such a big opportunity, not only for people to try and address or decrease their risk of future injury if they have had a previous injury, but also if you're someone like me. So I've never had an ankle sprain as far as I'm aware. I've fractured my ankle, but as far as I know, I've never had an ankle sprain, but it's something where I never want that to happen. My partner has had a lot of ankle sprains, similar story to yourself actually, except so far we've been able to manage him non-surgically, and knock on wood, he hasn't had an ankle sprain in like 2 years now. But it's something where I think certainly making it almost a part of your way of life of, hey, like this is a vulnerability or a weakness in how I move. Can I address this? Can I make it fun? I think, I love fun. We've talked about exercises and fun on here before, but I really think that finding, as you said earlier when we were talking, like your favorite exercise and just saying, hey, every day I'm going to do a single leg balance just because I know my right leg isn't as good as my left. That might be something that for some patients can help them just in a preventative or kind of a healthy body development long-term plan.
Yeah, body awareness I think is huge here, and that's kind of what we're touching on, is just learning what your body is doing and getting more information about what that might mean. So hopefully this plants the seed for that. But then you get the opportunity to physio for free within your day. You're waiting for the kettle to boil and you're balancing on one leg or doing your calf raises. That not everyone wants to set aside time for their physio exercises, so I'm fine with that. Like, I don't mind. Find it somewhere else. Integrate it into another part of your life. Maybe when you're walking, you notice that suddenly one foot doesn't feel the same as the other. Can you just be a bit more aware of how that feels and just try and change it when you're walking to the station in the morning? So there's so many ways of integrating it into your life. A lot of people go to the gym, and can you integrate an exercise into that rather than it being feeling like separate? I mean, physio exercises are inherently boring.
They're so boring.
So can you integrate it somewhere else so it either feels like you're getting it for free because you're boiling the kettle anyway and you're climbing the stairs anyway, or can you just put it in your gym program where you'd be doing a warm-up perhaps anyway? So I'm fully in with just adapting and playing these tricks on your brain just so it can fit into your life somehow. So I think it's important.
I call them microwave exercises. I know not everyone in the UK has a microwave. Everyone in Canada has a microwave. But what is your kettle exercise or microwave exercise? Do you do
mine's a calf raise? Yeah. Mainly because of my surgery last year, end of last year, that there is still a small deficit. We talk about the calf raise height. My right is still about a centimetre off where I want it to be. So I'm doing that calf raise height exercise when I'm waiting for the kettle to boil.
I have to be honest here. You've made me stressed about my calf raise height. I am going to be checking that. But after this, we both have patients after. But after that, I'm going to find you. We're going to do my calf raise height. No, that's just fantastic. In terms of going back to ankle sprain kind of management, just for the average listener. So of course, full medical disclaimer here. If you're someone who has any ankle pain for any reason, this is not medical advice. You need to go speak to your doctor, okay? But the reality is a lot of people, when they get ankle pain, they go speak to their GP in the UK or their primary healthcare provider, and they're often kind of dismissed in a way, which I think is a huge problem. And I'm sure you have the same experience as me, where I end up being that person to kind of try and get them listened to or try and find a path that makes sense to manage this issue. If someone has, tried to go down that route and they, they're relying on the NHS and they've been dismissed, do you have any advice for them on how to manage that?
Well, that's the tricky part, is that you go to somewhere like A&E or minor injuries units, expecting just to have the worst case scenario ruled out. That most people will think, I probably haven't broken it, but I'm really struggling to walk here, and they might type it into Google and what could be going on. You might have a fracture, you might have an ankle sprain. in that case, you need to go and have an x-ray. And you get there and you often feel, as soon as they've maybe x-rayed it and said there's no fracture, you immediately feel like they don't care about you anymore. You immediately feel like you don't need, and that's it's just an ankle sprain. And like, it's almost like, oh, well, they're rolling their eyes because it's like, there's nothing we can do here. And what they really mean by that, and I have some sympathy for them, by the way, right? That what they mean is, we can't help you in this environment, and the GP would probably fit into that category. We can't help you in this environment. You need to see someone who can, okay, which is physio, perhaps. What I believe they should do in that very moment is, here is a boot to keep your ankle fixed at an angle that allows it to heal again. What you must then do is take this boot off after, let's say, 4 weeks, because about 4 weeks, the healing will be sufficient to allow you to live your life normally. And what that then allows to happen is the ligaments that have torn, right? If those that are watching will be able to see this, the ligament fibers are intertwined.
Yeah.
They pull apart and tear, and then they're separate. If your ankle is then moving around, or like this, then the fibers that are like that never get a chance to lay back over the top of themselves and attach and heal.
Yeah.
So as a result, whatever healing might happen or doesn't happen is either really long and lax, and that's where long-term instability comes from, or not there at all. And again, that leads to instability in the ankle. Again, more sympathy. The reason they struggle to get on board with this in the NHS as an A&E GP automatic treatment pathway is that if you just give a boot to everyone in these situations, many people will maybe keep it on too long, get really, really stiff, and when they come out of the boot, they actually have different problems. Their ankle is too stiff, and then they can't get it moving again because maybe their NHS physio isn't for another 3 months, but let's say.
Yeah.
So I understand why they have the advice they have, because they almost make a deal with the situation and say, we'd rather have a lax ankle than an arthritic ankle that's too stiff and doesn't move, because a lax ankle still allows some function for most people, and for many people, by the way, they heal fine.
Yeah.
But it's the ones that don't that I see, and then they're the frustrating ones, just like me 20 years later, who's had to have stabilization surgery that would have been prevented had I've had a boot for the first 4 weeks of my injury, right? And I didn't know any different. I was just doing what I was told. However, 5 years ago, I injured my left ankle. It was actually a more significant injury.
Oh no.
A football injury, another sprain. Like I said, I'm on the bendy end of normal, so I'm more likely to have these than most people. I was a physio at this time. I knew exactly what to do. I went to the NHS, minor injuries, checked it wasn't fractured because I had definite bony tenderness and I was struggling to weight bear. I was 95% sure it wasn't fractured, but I did what I was supposed to do. And when I then challenged the triage nurse at the time and said, can I have a boot? She basically said, you don't get boots for these injuries. You just need to get on with it. The just word again. You just need to get on with it. Be careful for a few days. Rest, eyes, compression, elevation. I tried to have a bit of a negotiation and said, look, I'm a physio. I deal with these injuries all the time. I know that I'm supposed to have a boot here. And she was having none of it. Nope, that's not what we do. And like, that's her training. But yeah, it was quite a frustrating conversation to have. I was lucky to be able to go to the clinic I worked at and get a boot from there and manage it the way I knew I was supposed to, with an MRI later showing that I'd had a big significant rupture of 2 of my ligaments and a couple of other partial injuries with a big bone bruise as well. So a major ankle injury. I wore the boot for the time I was supposed to. I rehabbed appropriately, and my left ankle has never had a problem. So it was about 4 months and I got back to everything I wanted to do. Feels amazingly stable, amazingly strong. 5 years ago, not even the hint of instability. And when you test the ligaments the way that us physios and osteos would like to do, you can feel the stability of the ligament where they were given a chance to heal over the top of each other and heal short and tight again. So I've got nice stability through there. And that's why if people can, if they have an ankle sprain, which is a relatively common injury for everyone, let alone for hypermobile people, is to, if they can, get hold of a boot and immobilize it for a period of 3 or 4 weeks to allow that initial period of healing to happen. And after that, they then get moving, maybe see a physio who can help facilitate their recovery from there. But if not, just make sure that at that point they're then building up some strength, building up some stability, stretching through range, and it might be sore and it might be stiff because that's kind of the point of the boot. But that's a much more likely scenario to lead to positive outcomes and a nice, stable, strong ankle in the future, rather than the case where you have the laxity that we're describing in my other ankle.
No, absolutely. I loved your hand art description. No, getting those fibers to approximate, I think that's what helps so much, having this understanding from a professional perspective of what healing is actually going on, and the fact that those fibers need to find each other again. Yeah. And if they keep being pulled apart from each other, there is no chance for them to find each other and become friends again.
Yeah. I remember the nurse saying 20 years ago, just do this with your ankle, move it around. And now I look back and like, how on earth are those fibers going to get anywhere near each other when you're just pulling them apart at every moment? So
no, that makes complete sense. Question for you. Are there any ankle sprains where you wouldn't immobilize someone just in terms of management? Is there a mild enough category where... Yeah. And that's a really good point to make, because these are the ones where there's a massive swelling that's happened, and you can just see that massive swelling means big injury, which means... bleeding within the joint and around the ligaments. They're the ones where a significant structural pathology has happened. Yeah. If you just tweak it and it looks a little bit like a golf ball and then it goes down within a day or so, then it's not quite so important. Maybe you just soft brace it in those situations. So there's still a bit of support there, but it's much more of a soft, kind of almost like a tight sock. That they might be a better in between, happy medium. Yeah, they're on Amazon, like the figure of 8 kind of fabric ones, that type of thing. So I think having seen some big ankle sprains, they look like balloons for anyone listening. If it looks like your ankle is like literally like a balloon, that's immediately, make sure you get that medical attention, push for, that immobilization if that's something that is appropriate in your discussion with your healthcare provider, but make sure that those fibers can have a chance of finding each other again. I feel like that's the key message here.
And the first one, especially if this is the first injury that they may have had, they're the ones that are purple and blue, that the bruising is there because that's the bleed that's happened where the ligament has failed. It's ruptured, so or at least high grade tear. So if there is bruising, for sure, a lot of bruising, then what else could it be other than a bone? So once you've had the bone ruled out with x-ray, then you're left with a very, very likely ligament tear, perhaps muscle tendon ruptures as well. But again, that would be screened by your healthcare professional and checked. But if they are saying to you, we believe this is a ligament tear or rupture or sprain, then that should be immobilized if it is a significant high-grade injury.
Yeah, no, absolutely. In terms of ankle sprains, what does long-term kind of management look like? Because we talked about that, we have that injury occur. That person who goes to seek care hopefully gets some appropriate health care. What needs to happen from there? Because I find a lot of times it seems like the ball kind of gets dropped.
Yeah, well, I think in general, physio management can be highly simplified into these two categories. Yeah. So our first job is to calm stuff down. So that's the protection phase. That's what we're talking about here. Allow the body to do its thing. The body is evolutionarily designed to be amazingly good at healing. It's really good at that. That's how we are here today and doing what we do. But what it's not so good at is getting us back to performance and function necessarily, unless you're a highly active person naturally. So that's our job, really. So that's the second part of physio's job, which is to build things back up again. So we calm things down, build them back up again. So we've spoken a bit about the calming down phase of protection and allowing the body to do its thing. And maybe there's some argument for things like RICE, or as we now use, police.
Yeah, we have to talk about RICE.
There's lots of different acronyms, but essentially it kind of means the acute management stage is managed. And then you're onto the recovery part, the rehab part. And because we spoke about the mobilization, you are left then with muscle atrophy, because the muscle will waste away, because if you don't use it, you lose it. You're left with joint stiffness, because if you're immobilizing a joint deliberately, then it's going to get stiff. You're left with muscle tightness and tendon tightness. You're left with a lack of stability, so the skill of stability is lost, so you have to learn that again. And you're left with a less fit person as well, so there's even fitness there. These are all the things when we say build things back up again. Although we simplify the concept, that's the bit where your physio needs to be able to do those things with you and help you to navigate whatever you're left with. Yeah. So the longer term recovery involves making sure you cover all those bases. So measuring where you're at, how stiff is it, how tight is it, how big is it, how big is the muscle, how strong is the muscle, how stable are you versus the other side. Lots of different factors that that you would consider how, and not just the muscles are in and around the ankle, but further up the chain. What are the quadriceps, hamstrings, glutes, what are they all doing? And you don't necessarily have to have an individual exercise for each of these problems. I'm a big fan of efficiency within my sessions. So group stuff together, good bang for buck exercises that you can cover lots of different things all in the same exercise. But there is a process, and the people who follow it and do well, then they're the ones that have less chance, less risk of injury. There's a great study from many years ago that I quote all the time that still seems relevant to me today. People who don't do any physical rehab after ankle sprain have about 45 to 50% chance of re-injury. People who do have around 10%. It's a massive difference.
It's huge. I didn't know that 10% number. I knew about the re-injury risk and chronic ankle instability. Before we get on to that, we have to touch on RICE for a second, because there's been this whole thing. There was, RICE. I don't know what is up with RICE as an acronym, but no acronym has ever been as sticky as RICE. Like it is here, and it's hard to get rid of or change. What do you think of RICE for ankle sprains? And is it something that you advise your patients to do, or should they be kind of, you talked about how the body is good at healing in some ways. Should we do a bit of a less interventional approach for mild ankle sprains?
Mild ankle sprain. Okay. Yeah. Well, a mild ankle sprain, let's go through what it is. Rest, ice, compression, elevation. So my understanding is that complete rest is bad for everyone. Okay. So relative rest, is, and we'll come back to like a slight nuance on that. Relative rest, that's fine. Do a bit less. Ice. If your pain is so bad that you want to take painkillers, but maybe don't want to take painkillers, like we're going to have to go on a tangent. I hope you don't mind. Okay.
I love a tangent.
Okay. Well, anti-inflammatories, very commonly prescribed for people with musculoskeletal injuries, ankle sprains especially, to help bring the swelling down. But the evolutionary process is designed for swelling to support recovery.
Yep.
So if you take anti-inflammatories in the early stages, and we're talking about the early days and maybe the first week, then you are disrupting the healing of the structures. You're getting in the way of the natural healing. So when I think about, optimal management and protection of that early phase, try to avoid anti-inflammatories if you can. And the only reason I would say that sometimes people need them is if they're not sleeping.
Yeah.
So if you're not sleeping because the pain is so bad, in that situation, it makes sense that you would then take anti-inflammatories, because sleep overrides it altogether. That is our superpower for recovery. So you do need the sleep in order to recover. But if you can sleep well without anti-inflammatories, try not to take them in the first week, especially after a major injury. Minor injuries I'm not so bothered about, because it's probably going to heal anyway, regardless of what you do. But just have it in your mind that it might not be a blanket answer. And by the way, this is another gripe of the healthcare. The healthcare profession in general, the acute management is, here's some anti-inflammatories, take them.
Yeah.
Again, I understand they probably don't have many other options to help people in pain, but hopefully the nuance I've given you there gives some people an option. And this is where ice does help. If you are struggling with pain and you have sensibly listened to what I'm saying here and have decided not to take anti-inflammatories, ice is a great pain reliever.
Yeah.
What it probably isn't is an anti-inflammatory itself. So people think of ice as something that brings swelling down. The evidence is pretty unconvinced about that nowadays. That it maybe doesn't act as an anti-inflammatory the way we used to think it does. What does act as an anti-inflammatory is compression. That's the C for ice. So compress it with some kind of tubey grip, bandage, wrap, not too tight so you cut off the blood circulation, but tight enough to feel like you've got a compression going on. That should help with swelling. The other thing that is believed to help is elevation, and that's purely physics. Gravity will help to drag the excess swelling that's maybe not needed for healing. It will bring it back, and also just optimize the blood flow to the injured area.
Yeah. No, absolutely. I was reading too about how important it is to have elevation if you're going to do it really up higher than most people think it is. It needs to be above the heart to have any effect, based on what I've looked at. No, it's funny. I'm sure for you growing up too, I was just having bags of peas thrown at me and like ice packs, and I was in a lot of discomfort. It was making my symptoms worse, and it was deeply unpleasant and not helping me. So I think totally it depends on the injury, how it's affecting that person's symptoms, and what the actual presentation is. And this is why it's key for the explanation here. It's for pain relief. Yeah. So if it's not giving you pain relief and it's too cold and it's hurting, then take it off. Yeah. It's not doing its job. Don't get an ice burn as well. Like 15 minutes, 20 minutes, that definitely no more than
that, like maybe not even that. So I know people who have had ice burns and they're not fun.
That's why I tell my patients, I'm like, do not burn yourself. Do not injure yourself with heat and with ice application. I say that they think I'm joking. No, I'm being incredibly serious about this.
Can we go deeper on the acronym?
Yeah,
So
of course we can.
So we evolved from RICE into PRICE.
Yep.
So they added the P, which is protect. I really like that because we should be protecting the injury. And that's the bit that I prefer is around allowing the injury to do its thing and allow the body to do its thing. They then got clever and did police. So police, which is protect, OL, optimally load, and then the ICE on the end. So I like the optimally load rather than rest because it then suggests that a minor injury, you can still move it. You don't have to rest, but you're just being sensible. It gives it, the coach in me again, it gives the person a decision to make for themselves what feels like the right amount of load for this injury. And for some injuries, it's different to others. And then they did peace and love, which I can't even remember all of them.
It's too many letters.
Because it gets confusing. And if you look at it, if you read it, you're like, oh, that's quite cute and that's quite nice. But I think it gets a little confusing.
No one can remember. The V is vascularization. I don't know the rest of them. But peace and love.
Empathy, I think's in there as well.
Is it empathy?
Yeah. So, yeah, I think it gets a bit much.
Going back to like the coach in you and mindset, I do have to say, you know, you and I see people who are down. And I think after an ankle sprain in particular, because of how dismissed it can be as an injury because it's just an ankle sprain, which it's not, people often have this perspective, I think, that, you know, they're never going to get better and it's injured. And although the, you know, general management can be quite poor when patients are interacting in environments where they're not able to access care that's appropriate, as your, you know, your personal story has demonstrated, and as, you know, your work with patients shows, they're highly treatable injuries that can have good outcomes if we do the right thing. How do you kind of coach or physio-coach your patients in mindset when they're dealing with an ankle sprain?
Well, I can't help but just lean on my story again. And it's for 20 years, my ankle was fine. You know, like it recovered well enough for me to play rugby for 15 years, for me to run marathons, for me to lift heavy weights, you know, to do what I wanted to do and, you know, climb mountains. So it was coping just fine. I just knew it was a bit different. And I think we even mentioned this offline as well, that we sometimes do have these forever injuries. When they're major, they can just leave their mark a bit. And you might just have to do something to keep on top of those forever. But I was still highly functioning. It was only that most recent sprain that I had when I described it running that led to me not coping. So that's the key. Like, are you coping or not coping? But you're absolutely correct that the vast majority of these are highly treatable, highly rehabable. And it's just about identifying the deficits that are attached to the reason someone is not able to do what they want to do. And often it's the deficit, the secondary part of the injury, the weakness, the lack of muscular stability or the loss of the skill that happened after the injury that's more of a problem than the structure itself. And they're the bits that are really treatable. So that's what I'm doing in my assessments. I'm looking for reasons that explain the person's symptom. And I'm looking for the stability of the ligament. Like, has it healed long, or has it healed nice and tight and short? Do they have good stability on one leg? Do they have all those things we mentioned earlier, calf strength, range of movement, so that's sufficient for it? I think we sometimes make a little too much of range of movement to some degree. You know, most people just need adequate flexibility in their ankle.
You just need enough.
If anything, most people need a bit less if possible. That's what we're speaking about with people who are hypermobile and have lots of flexibility. If anything, a bit stiffer wouldn't be a problem.
Yeah, more range means more movement you have to be responsible for. Can you control that? You know, getting to shoulders in a second. For me, I have very hypermobile shoulders, and I had to build up so much muscle mass just to be able to control that range of motion. And the amount of work and rehab it takes is huge, I think, for people who are hypermobile. Getting into kind of long-term management, you know, these people who get chronic ankle instability, could you tell me a little bit about that? I assume it's something you see in hypermobile patients. I know it's certainly something I see. And how do you have any tips on managing that, or when people might need to be aware of that?
Well, if I just finish the final point, then we'll kind of move through.
Sorry, please go back.
Because it sort of goes through to it. It's
perfect.
One of our superpowers, I think, as healthcare professionals is our ability to confidently assess and support someone in that. Listen to them, understand their problem, confidently assess, give them a diagnosis, and reassure. It's one of our most powerful treatments, to reassure someone with confidence, not just to flippantly say, you'll be fine. You know, it's just an ankle sprain, you'll be fine. That's not reassurance. That's dismissing. So if we can reassure someone that here's the right plan for you, we can look after you, then we move into that kind of long-term management of someone who's who's got chronic ankle instability that we're maybe picking up a little later, then they need all the stuff we've said already. So identifying the main problems that are leading to that chronic ankle instability.
Mm-hmm.
But most of those do well. They do still do well. They don't all need surgery. In fact, most of them don't. If anything, it's the other way around. The key is, like, are you coping in your life with what you have? Let's identify the problems. Let's try and solve those problems. So are you strong enough? Are you stable enough? Or are you well balanced enough, should we say, to compensate for the lack of ligament stability? Do you have sufficient range of movement? Do you have the right level of muscle power to do the thing that you might be doing? Are your tendons springy enough? If our physio journey can solve all of those things, and then they don't have instability episodes anymore, job done.
Love it.
We don't need surgery. I've had many patients though, and unfortunately it's probably I say many, I'm thinking of probably about a dozen patients in my career where we go through all of those things, they solve all those problems, and it still lacks.
Yeah.
And they're still having instability moments, me included. So sometimes there's no failure of the physio. It's just that your ankle was never quite going to make it, really. And you can't tell which ones they're going to be. But sometimes the ligament or the structural pathology wins in the end.
Yeah.
And that's the shame of it. But there is still a solution for those people, and surgery can work very, very well, even when your physio rehab hasn't quite done the job.
Yeah, no, absolutely. I'm always shocked at how many people I see who've had, multiple ankle sprains and a history of chronic ankle injury where they haven't had sensible imaging either. So they've just been told, without any investigations, it's an ankle sprain. And it's like, you get them imaged and there's something really serious.
Well, look at me, right? 20 years later, I didn't really need it prior to that, other than at the original injury. And there it is. It's like, wow, that's worse than I thought it was.
Yeah.
I thought I probably had an ATFL injury, and there's two others that I had picked up on. So.
I do have to say, for me, this is just one of my clinical management decisions, but a traumatic onset plus noise, like for me, it's instant pretty much, do not pass go. We're getting, also I do work with people who are hypermobile, so my threshold for imaging is much lower. I would say I'm very careful with that.
I nowadays I do the same.
Yeah. We do not mess around. I have a question for you. So one analogy I use with my patients, I try to describe to them, I say, look, when it comes to your ankle, I think of it there as being a structural component, like a race car, for example. And then there's you, the race car driver. There's how you control the joint and the neurological function, basically, of it. And then there's the actual, the ligaments and the bones and the tissues that make up the joint. And although we can do a lot of exercises where we're trying to develop better neuromuscular control, in some cases that ankle, that race car, might be so, poorly built or just not functional that even with the best race car driver in the world, it's not going to go. Are there any analogies or descriptions or ways that you describe things to your patients when it comes to ankles that you'd like to share?
Well, I'll use my analogy that I like for the body and pain and injury in general, which I like the garden mentality.
A garden,
yeah. So I sometimes I like how you've connected the mechanical car to the biological person, because that's the key. And sometimes people think of their bodies as purely mechanical. Any pain or any problem I have can be fixed or not fixed, and if I am still in pain, it must be a mechanical problem. We won't get into the weeds of chronic pain necessarily here, but it is more complex than that. It's way more varied as to how pain can present.
Absolutely.
So hence why I like the garden metaphor, because I do treat a lot of people with chronic pain, and it helps people to see that there's so many factors involved, and you need to have all the right ingredients in order to optimize healing. And let's say. So when I moved into my new build house 13, 14 years ago, we were left with a pile of mud. We didn't get grass. We decided we'll just figure that out when we can afford it, right? So we didn't get the lawn put down. We just had a pile of mud in the garden. And I didn't know anything about it, so I had to learn. And I thought, well, we'll just buy some grass seed and we'll just throw the grass seed on there. And we had mixed results with that. Some grass grew through, some didn't. And then we got a load of weeds that came through. So we had to scratch our heads. Okay, what do we do next? Okay, so... some parts of the grass are getting loads of sunlight and some are not because of the wall in the way. So I'll tell you what, we'll stop trying to grow grass there and we'll grow plants there. So we've got some different ones there. And then we have to figure out a different way. Okay, they need to be watered now. We can't just expect them to grow, so we have to water them. So we need sunlight, the right amount of sunlight. We need water, the right amount of water, not too much, not too little. We need the seed to grow. We need the plant maybe. We need to go out and manage it. We need to go out and cut the grass sometimes. We need to trim back some of the plants because they're a bit big. Some of it dies because we don't quite get it right. So this is part of that structural. Sometimes you try your best with it and it still doesn't work out. I've had many plants that we've bought that have died, and there's bits of the grass that seem to get more weeds than others. So it needs some attention, and it needs an awareness that there's so many factors involved that we're not always conscious of, that we have to let things happen to some degree the way they're supposed to happen, the way biology designed it to happen. But the more we learn about it, and the more we try to learn and get feedback from these things, the better we get. So by the time we left that house, the grass was pretty good, actually. We had some thriving flowers on the outside and the borders because they did well in slightly sheltered areas. So 10 years later, and our garden looks way better than when we turned up with our mud. And I think that's the way we should think about our bodies in general, that we have to nurture them. We have to accept there's things that happen that we don't always understand. But if we're mindful of it, we can learn from it and we can figure out a strategy to solve it. I'm just trying to help be the gardening expert for people's ankles here, right? Just shortcut some of those decisions that it took me 20 years to some degree to figure out, certainly for my own one, but certainly my physio career, even there's a process of trial and error. So it's just, and I'm still not done learning with this stuff, right? There's still more I can learn, both with the garden and ankle sprains.
I think I'll be coming to you for some gardening tips in future. But no, I love that analogy. And I think that idea of looking at a failure as an opportunity in a way. And sometimes different interventions will be needed. Maybe there had been something really messed up going on with your soil or your pile of mud, and maybe you needed some new soil brought in. Some interventions are much more large scale than others. But I think that idea of looking at opportunities for improvement and scope of improvement is key. And I think, again, that's where a physiotherapist or another healthcare provider can come in and say, like, hey, I know this injury. This is how we can manage this. And prognosis, I think that's the one thing I'm really a stickler for too. I hate when patients get told, come once a week for forever and there's no outcome measures. Like, if you weren't growing flowers in that area after 3 years, you're going to be like, what's going on? You'd probably say it after 1 year.
I'd probably hire a gardener.
Yeah, and be sensible.
Yeah, sack myself as the gardener and I'll hire another one. Yeah,
absolutely. Sometimes you have to sack yourself. Question for you. When it comes to chronic ankle instability and people who are hypermobile, and I guess I know you're not technically an expert specifically in hypermobility, but you see every physio, every osteopath, everyone's seeing hypermobile patients. Are there any interventions you like to try and just support them in feeling their ankles better? Obviously, there's exercises. We love exercises. But are you a fan of anything like patients using tape, maybe, or other things there?
I think tape is a hugely valuable way of supporting the ankle recovery journey in different ways. So firstly, if someone comes into me and they have just sprained their ankle, and I mean just in a different way, like literally it's just happened.
Yep.
If they come in with a fresh ankle sprain and they don't have a boot, and we've not got one in clinic, then I will tape it as the immobilization, and I will say, I want you to keep this on for a few days and try and get yourself a boot in the meantime.
Rigid tape or okay, cool. Love it.
Zinc oxide. Yep. And this is where my sports,
pitch side.
my sports background really helps. So I've strapped hundreds of ankles in my time, so I can
fantastic.
Just it should be. It's tricky to do, actually. It's quite a difficult technique because you can over tighten and miss the right angles. But anyway, that's one thing I really love doing, is just helping someone immediately go, right, this is now protected and safe.
Yeah.
The other end of it, if they're getting back into exercise again, and I think this is especially relevant for people who have more flexibility than the average, no matter how much rehab they do, they'll probably still feel a bit wobbly and a bit uncertain. I think tape is a really valuable way of building their confidence. I think it's especially important, again, if someone is sporty, and it's like a change of direction sport of some sort. I will encourage them. I'll either do it for them if I'm seeing them often enough, or teach them how to self-tape. Again, that coach again is coming in. Teach them how to self-tape and say, please tape for the first month or so of you returning into sport or exercise, just to reduce that risk of it rolling, spraining again in a perfectly innocuous way that I just don't want that re-injury to happen. So the best way to do it is to tape it, really.
I love how much you care about people's ankles, by the way. I am like, if someone out there sprains their ankle, you need to contact Charlie. You have a deep... I
think a lot of empathy comes when you've struggled yourself. I think, and the expertise plus the empathy comes when I know how tough it can be. And hence why we're here today.
I love that you teach people how to tape, because I see so many patients, again, they've seen other people in this field and they haven't been taught how to tape. And this is someone who's getting really, really mild ankle sprains regularly, nothing major. But they're getting some ankle pain or they feel unstable, even if the ankle's not actually that unstable. And I'm a big fan of saying, we can use this tape to give you some more proprioceptive feedback, even if it's not from trying to make the joint more stable. I want them to be able to better feel what's going on in the ankle. Do you ever use tape just for kind of proprioceptive purposes?
Yeah, I just get them to video me applying it on them. And
it's so easy.
I talk them through it. It's like a very simple thing to do and helps them to go away and manage it better. Yeah, I think that if they are worried, not sure, not confident, then anything to build their confidence to be active. Ultimately that's the headline in the end, is like, I want people to be active and healthy. So anything that builds confidence for that, I'm happy about. So kinesia tape is another type of tape, which I don't tend to use much for ankles. I just don't think there is enough to add to the stability that I'm keen to get. But there are still some people that say they like the feeling of it.
A lot of my hypermobile patients, they love it. I get hives from tape.
So even though I wouldn't use it as a structural limitation. If someone says it feels good, I'm cool with that. That's good enough for me as well. So I don't mind.
And even if it's placebo effect, too. I love placebo effect. People are always really quick to put things down.
You know how powerful placebo effect
is? It's super powerful.
They use placebo to measure drugs against. They don't say no drug. They use placebo because they know that placebo is a drug in itself. I think it's like 20 to 50%. And even when people know it's a placebo, it still works. That's how powerful placebo is.
No, absolutely. When it comes to applying tape, what I will say real quick, just for any hypermobile listeners, is you have to be careful with wounds. You don't want any puckering of the skin. And again, here I'm talking KT tape application. I'm not talking rigid tape. I'm talking stretchy tape for proprioceptive feedback. But these are people who are generally a bit more prone to having things like hives occur and different things. So be cautious, talk with your healthcare providers, and just make sure that you're taping in a way that's safe. Also, I'm pretty strict on anchors. So that piece of tape that's not stretched, a little bit of stretch and then some stretch. Because I've seen people just yank it and apply it on videos online. And I'm just like, oh my gosh.
Yeah.
That's going to lead to bad things.
The other thing is the adhesive is, some people are allergic to that and they get real bad reactions to it. Both the zinc oxide, the rigid stuff, and the K-tape. If you get a reaction, just take it off. It's not worth it because it can really, really scar. So it's not.
Wounds are serious stuff. I have a colleague in the field who finds Coloplast. It's like a spray that's used for colostomy bags. He swears by it. I haven't yet tried it, but maybe one day you or I will get around to trying it and see if it helps. I
use the underwrap a lot for the zinc oxide tape, just to try and protect the skin as much as I can. That the Hyperfix that works really well. That you can't use it on every single part because then the tape doesn't do its job. But I try and protect it as best as possible.
One other weird thing I'll say is, have you ever seen 4-way stretch tape? It's not K-tape. It's different.
I have seen it.
Yeah. So I do find that some patients will get hives to, they'll react to K-tape and they'll react to zinc oxide tape, but they won't react to the 4-way stretch tape. I wonder if it's because of how it moves more with the skin. I have no idea. It's expensive, but sometimes I'll just like triple layer or double layer it for people where that's appropriate. But it's the one type of tape I don't hate, or I should say my body doesn't hate. When it comes to exercises, just in brief and really simple terms, are there any things you like to think about with patients in terms of that long-term management? So, there's like 2-footed exercises, 1-foot exercises, any basic kind of thoughts there?
If we're thinking really about ankle stability and strength here, you develop stability in particular on one leg. It's very, two-leg stuff doesn't really do it. Because the other leg stabilizes for you. So it's like it was perfectly fine for general strength, but not so much for ankle. So you need to be on one leg, or at least in split stance. Split stance can offer some good stability too. So I'd probably start with the split stance exercise actually, and then develop into a single leg. I mean, the best exercise for it. And
what's your favorite?
Like, I'm going to put it out there. I normally don't like these, but the best exercise, the one I give to everyone who has ankle instability, is a single leg sit to stand.
I love it.
Because you can modify it to the person. It's always going to be a stability challenge. And you can modify it to the person. You can make it a really high seat. You can make it a really low seat. You can get them to hold a weight. They can be on a slightly unstable surface. It's the best exercise because I can modify it to the person and to the demands of their exercise goals. So Single leg sit to stand. You heard it here now. That's the best one.
I love it, and I feel so chuffed. I call it a single leg partial depth squat. Your name is much better than my name. But yeah, you can't hide from it. All the vulnerabilities show up in regardless of what joint they're in. Yeah. Charlie, this has been fantastic. I've kept you for so long. Thank you for being on here today. Is there any final tip you want to give people? If you could go back in time to little Charlie with his first ankle sprain and he's being told it's just an ankle sprain, what would you want to tell him?
Just don't tolerate it. Just don't. If someone tries to minimize it, don't allow it, and find someone who's willing to give you the time of day for it. And it's up to that person that you then go and find to solve the problem with you. But don't tolerate someone minimizing an ankle sprain, because it can be a serious injury.
Yeah. Thank you so much again, Charlie. And if you're looking to find Charlie, we will put all of his details in the show notes. He's here in London, like me. And hopefully we'll be able to have you back another time, maybe to talk about chronic pain or something else. Who knows?
You're welcome. Thanks for having me.
Thank you again, Charlie.